Good afternoon, everyone, and welcome to our Paediatric Dermatology in Community Pharmacy webinar. My name's Lindsay, if you've not met me already. I'm the Healthcare Development Manager for CPLSC. I know I've seen lots of you out and about at our lovely event a couple of weeks ago, so that's been lovely. So today's session will be recorded if anyone's teams want to watch it back, and will be available on our YouTube. We'll pop that notification on the newsletter so everybody can jump on and have a look. The session's about an hour long. I have left some time at the end for some questions. So any questions throughout, either jot them down or pop them in the chat. And then once we get to the end, I'll pop through and answer any questions. Basic housekeeping. I'd love if your cameras are on. I'd like to see some faces, but microphones off where possible, please. Just to prevent any disruptions, that would be lovely. So lots to cram in. So let's get started. So why are we covering dermatology for community pharmacists? Well, skin conditions are so common in paediatric patients. I know from my nursing background myself, the most things that parents bring to you are, rashes, which we've covered previously, and skin conditions. So it's just trying to differentiate between the different types. And again, as I've said in previous webinars, we're not expecting you to be experts, but it's just noticing the signs, noticing the symptoms, knowing when to treat and knowing when to refer on. Hopefully, with lots of the outreach work we're doing and all the comms from ourselves, NHS England, CPE, patients are starting to seek pharmacy first. So one of our big pushes at the moment is for people to get the right care at the right time and the first time. So that's something that we're really pushing on at the moment. So it's lovely to see that patients are building that trust and that rapport with community pharmacy, and starting to seek help with us first where appropriate. Naturally, we do get the ones that we can't see, but we'll cover when to refer and things during the presentation as well. With Pharmacy First and obviously increased patient footfall, it does increase our clinical responsibility as pharmacists, as clinicians. So it's just making sure that you're confident in your decision making and your assessment process. I covered this in the last webinar as well, but I'm going to cover it again because it's so important. So referrals from GPs, naturally it makes our lives easier in community pharmacy, following that process, but also it's a patient safety aspect. So there's an auditable trail of the referral, of the treatment that you've provided or the advice that you've given, which is fed straight back to the GP. So that patient never drops off the system and nobody knows what's happened. The only acceptable rationale for rejecting patients is if you're unable to get in touch with, in this instance, because we're talking about paediatric patients, their parent or their caregiver. When we talk about contacting parents and caregivers, I think one thing to bear in mind, especially with younger children and unwell younger children, is if you've tried for the first time at say 10 a.m. and you can't get in touch, maybe give it an hour, 2 hours before you try again, simply because there is nothing worse, speaking from experience, as a parent, when you've been up all night, you've had a horrendous night with your child, and then the phone rings and you miss it, and you might have been up at 8 already to try and get a GP appointment, then you've been referred. So just bear that in mind and just have a little bit of patience, trying to get in touch with them sometimes. So the basis of any assessment is structure. So we want to be using a consistent assessment framework, which supports our decision making essentially. So the key things we always want to be asking is child's age, which if they've had an electronic referral, we'll know most of these details anyway. The duration of the skin condition and the progression. What does it look like? Where's it distributed? Often parents can say, oh, well, it's just on the face and it's on the chest. But ideally, we want to be having a look, which is why we've got such lovely clinical consultation rooms now as well. We want to be having a look at everywhere where it spreads, because skin conditions can spread quite rapidly in children as well. We don't want to just make sure that we're covering all bases. Is there any other things going on? Any other systematic symptoms? A fever? Naturally, we're looking at red flags there, thinking about, things that are going to need a referral on. Our unwell children, any non-blanching rashes, any rapid deterioration. skin conditions on their own are usually quite treatable in community pharmacy, but paired with any of those red flags, fevers, vomiting, irritability, and things like that, we want to be referring those on. And any contacts on recent illness, a lot of the conditions we go through today, once one child at nursery or at school has got it, they're all going to get it. So just getting that history as well. Oh, it might help your decision making. Oh, what's going on at nursery? Has anybody at nursery been off with anything? Yeah, half the class has had chicken pox. You're likely going down the chicken pox route. Similar with impetigo in young children, they're all slavering everywhere, touching each other's toys and stealing each other's drinks. So once one's got it, it's going to spread like wildfire. And that just helps your decision making. So most common, I would say, chickenpox. So 3 stages to chickenpox. It starts off with these spots, can be itchy, and obviously we're trying to get children not to itch, which is impossible. Usually presents on the trunk and the limbs. Very severe cases, you can sort of get them widespread across the face. So it tends to be more your stage 2, where they become widespread. One thing to note for our guidelines and things like that, any chickenpox spots, any rashes, skin conditions within the 2 centimeter radius of the eyelid and the top and bottom lid, we wouldn't be seeing, we'd be referring them on. So they might spread, they might stay in a small area, depending on skin tone. They can be red, pink, darker. Some of them blend with the skin tone and just appear as more bumps, and they can be hard to see on brown and darker skin. For stage 2, we're looking at then the blisters. The spots start to fill with fluid and they're really, really itchy and they might start to burst. And then stage 3, which is when they can be reintroduced back into school and things like that, is when the blisters have formed scabs. Some of the scabs might be flaky, they might still leak fluid, but as long as they've started scabbing over, the general advice is they can go back to childcare, school, because that's always one of the most common questions on parents' minds. When can we get them back into school? Because I'm off work. So it's just dealing with that 3-stage process. And really with chickenpox, it's just trying to make the child as comfortable as possible. We can do oat baths, chamomile lotion. There's all sorts of things. I'm sure you've got loads of lovely lotions and potions in your pharmacies that you like to recommend. And certain clinicians have things that they feel works best. Families have things that they come in and request. So it's just finding a treatment that they're happy with and you're happy with as well. So it has an incubation period of about 2 weeks, 13 to 17 days really. So again, getting that history. Has anybody at nursery, has anybody in the family had chickenpox? And then it is likely that within that 2-week window, this child will then start presenting, and it's important to give that advice that you've now got an incubation period of 2 weeks for anybody that you come into contact with. And usually you're infectious around about day 4 before the rash and the spots actually appear. And then once the rash has started appearing, you remain infectious then for about 5 days after. So you've got a 9-day sort of window there where previously back in the day, mums would have chickenpox parties because obviously they wanted the children to be exposed to it early and just get it over and done with. Luckily, we do have the introduction of the NHS chickenpox vaccine now, which seems to be working pretty well. So things might change in that sort of retrospect. So I did talk about skin tone variations. This is kind of just a little visual for you there on how it can present in different skin tones. Can be different textures, shapes, sizes, but it's just one to look out for, and definitely one to be having a look at where possible so you can differentiate between the different skin tones. So what can we do in community pharmacy? Antihistamines for the itch, because they are very itchy. Any emollients, calamine that you've got on stock that you can recommend. And it's really important that we're reinforcing the importance to parents that just paracetamol. Lots of parents want to jump in with ibuprofen, but we know that can cause a reaction, that can cause the chickenpox scabs and spots to be more deep rooted and can leave scarring and things like that. So yes, they might be quite unwell with it. They might have temperature and they're really uncomfortable, really itchy. But it's just having that real clear conversation with parents to avoid aspirin products and ibuprofen products in line with our NHS guidance. So we don't want to be seeing any patients that are less than 4 weeks old. Naturally, we don't tend to see children below 1 in community pharmacy anyway, as sort of a rule. Anyone that's immunocompromised, hopefully GPs aren't referring these patients anyway. Any with a secondary infection, and then if the child is appearing systematically unwell, we would be referring them on, depending on the time of the week it is. And actually, we need to be looking at, can they be referred back to the GP? Do we need to be looking at urgent care, 111, a walk-in centre, etc. And we'll cover some signposting and safety netting later in the session. Shingles in children, rare, I would say, but is possible. For shingles, antivirals are so time critical. It's really important that any suspicion of a shingles case is referred straight back to the GP, or if that's not possible, straight onto an urgent care provider. Comes as sort of like a unilateral rash, so you'll have sort of your darker spots and rash in the middle and be surrounded by a slightly pinker rash around the outside of each of these clusters. I can't say I've had shingles, but patients that I've spoken to that have had shingles say it's sort of like a pain, a tingling, like a burning sensation. So it doesn't sound very nice at all. It can be widespread, can be all over the body, or can sort of localize to sort of your neck, your trunk, your arms, those hot places where you've got a lot of contact with clothes and things like that. Makes it really itchy. Starts as this red rash and it sort of develops, if you look really closely, into really tiny sort of pinprick blisters that'll be localized to one area, and then you'll find that you're getting these patches everywhere. Can last for 2 to 4 weeks. So it's definitely not a quick fix, but again, that's why those antivirals at the earliest opportunity are so important. Children who are at higher risk of shingles, again, this is why it's so important to get our background information. So any child that's had chickenpox before the age of 1, and any child that has a weakened immune system to any conditions or treatments they may be going through, think sort of like chemotherapy or immunosuppressants or anything like that, they are more likely to present with shingles. Scarlet fever is another one, seems to be doing the rounds again at the moment. I do still touch base with my previous job as a nurse, and I do still practice occasionally, and we're getting lots and lots of reports of scarlet fever at the minute. Can be known as fifth disease. I've actually not heard anybody refer to it as fifth disease in quite a long time now, but slap cheek is really common. A lot of parents will refer to it as slap cheek. It features a sandpaper type rash. You can really see that it's really textured. They can have a bright red, what we call strawberry tongue. Muted. Just imagine you'd be eating a full punnet of strawberries and you've got a bright red tongue and a bright red mouth. And very, very often they've got a fever, they've got a sore throat, and that's because they've got the scarlet fever infection in their throat as well. First symptoms you'll usually see is they're not right. You know, parents will say, oh, I've been watching them because they've not been quite right. And then they've started with a high temperature, complaining of a sore throat. Often you can physically see that their glands are swollen. Obviously, with younger babies and toddlers, it's really difficult because they can't really tell us what's wrong. So the scarlet fever seems to progress into the rash before we realise actually what's going on. Once they've started these cold and flu-like symptoms, the rash tends to appear a day or two after, and it looks small, raised red bumps. Tends to start on the chest or the tummy and then spreads. And as I say, it's quite sandpaper texture, so it's quite an easy one really to diagnose because it does have a really distinct look in texture. The rash doesn't tend to spread to the face, but the reason it's referred to as slap cheek is because their cheeks just absolutely blow up bright red. And the rash and the slap cheek can last up to 3 weeks. So again, it's not a really quick fix. It doesn't go away very quickly. As with most skin conditions and infections, you are infectious before the onset of the rash. So it's important that if parents have got other children at home or a child is going to childcare, nursery, school, that we're letting them know so they can let other parents know, or they're aware to look out for similar symptoms in their other children at home. It's mostly spread by droplets. So typically they start with the cold and flu, start coughing and sneezing first, whilst they're infectious, spread it everywhere, and then you realise that they've got scarlet fever. There's been a lot of buzz recently about scarlet fever. It's really important to be highlighting the health implications to the public. So with spreading it in advance of you even knowing what the rash has become, you've got to then sort of think of who your child's been into contact with and who you need to be speaking to about that. If we don't commence antibiotics, the infection can be spread for 2, even 3 weeks after the symptoms start. So it's important to try and diagnose as early as possible and get those antibiotics started to prevent any further spread and implications to the public. So this is what it looks like. Again, I've tried to put a different couple of skin tones in there so we can get a bit of a idea of how it might present on different skin tones. Quite a severe case with the picture with the mouth there, but that's what I mean, the strawberry tongue. It's bright red, can often have that white film over the top of it. The slapped cheeks, funnily enough, this is actually a picture of my nephew. Slapped cheeks look like they've run 10 miles around the block, and they've come back, but it's still the smooth surface. It's not the rash that's spread to the face. As you can see on the chest there, that's quite a severe case again, but that is what it would look like. That really prickly, rough, red looking kind of rash. Impetigo, very common one. If any of you know school nurses or have dealt with school nurses, once somebody whispers the word impetigo, it all hell breaks loose. Because it's so contagious. It's usually not serious, but it spreads like wildfire. Most common in young children, so you'll see a lot of children in nurseries and things like that. Obviously, we can treat this with our Pharmacy First formulary because it's one of our lovely seven common conditions. And I have actually seen patients coming in for treatment whilst I've been out and about on visits. So that's nice that the message is definitely getting out there. So impetigo features these honey-coloured crusts. Could be confused for cold sores initially, tend to be around the nose, the mouth, lower chin, and things like that. As I say, highly contagious, itchy, sore. There's a link gone in there for the Pharmacy First formulary if you need to save that. So usually we go for the fusidic acid on the PGD. But the most important thing really is hygiene advice. We don't want this to be spreading any further than it is. And like I've said, children sharing toys and drinks and things like that. It's often not easy to prevent the spread. But that real focus on important hand washing at home and things like that. Again, the redness can be a little bit harder to see on darker skin. But the blisters, they burst quite quickly, and that's where the crusty kind of common impetigo look comes from. It's not so much dry skin, it's all the blisters that have burst and they leave these like golden brown patches. I have heard people to refer to it as it looks like there's cornflakes stuck on your skin, so that's kind of what I mean when I'm saying brown patches. Once you get a couple, they spread really quickly. They get bigger in size, they spread to other parts of your body. As I say, it's usually located to the sort of the chin and the lower face area. Very, very itchy, I'm told. And obviously as the more we're itching and knocking scabs off, they're getting sore and they're getting painful. So the sooner we can get some sort of treatment on there, topical treatment, reduce the spread for a start, but we're also going to make that patient a little bit more comfortable. Another one, I don't know why my microphone keeps muting. So hand, foot, and mouth, really common again in children. It can affect adults. But most of the children, and again, it's just because they share things and they're grotty, aren't they, kids? You know, they're just a bit grim. So presents, so they'll start with a cough, a cold, sore throat, high temperature, sore mouth. Again, little youngsters that can't tell us what's going on. It's important just to have a quick look in the mouth or ask parents to look in the mouth. And then they have this rash on their hands and or feet. It doesn't have to be hand, feet, and mouth. It can be one of the three, two of the three, three of the three. But once you go through your sort of like clinical assessment, you'll figure out which, if any, or all are being affected. So it's easily passed on to other people, spread with bodily fluids, coughs, sneezes, anything from the nappy area, fluid in the actual blisters, and you can get it more than once. So this is where it gets really difficult in nurseries, in particular. One child will have it and they'll spread it around the whole nursery. And then by the time the last child starts with it, the first child's finished, and then they might pass it on again. So sometimes it's encouraging parents to have conversations with nursery and just say that place just needs a really good deep clean. Otherwise, we're not going to prevent the spread of this, and we're just going to keep going round and round in circles. Similarly, at home, siblings passing it on to each other, and potentially parents. Parents aren't, exempt from hand, foot, and mouth, but it is more rare in adults. You can start spreading it from a few days before you have any symptoms, but you're most likely that the height of the spread really is in the first 5 days after symptoms have started. And by symptoms, I mean the cough and cold symptoms that come first, not the onset of the rash. So what can we do in community pharmacy? The mouths are really sore, they're filled with blisters. Obviously, we've got to be cautious on age of the child or the toddler or the baby, but we can look at sort of mouth ulcer gels, how effective they actually are when you strip back the science. Not sure, but parents seem to get some relief from the fact that they're doing something. And then sprays are a good one. And then for your older children, our mouthwashes. Analgesia, just to make them a little bit more comfortable, manage those other symptoms that are going on, and lots of fluids. Although they've got a sore mouth and they're probably not feeling up to it, we know with any unwell child, the best thing to do is just push and push and push fluids. So this is kind of what it looks like. Very faint rash, starts as sort of spots, and a lot of the time it's mistaken for chickenpox initially, but they will be located to the hands, the feet, whereas obviously our chickenpox starts on our trunk. Some of the blisters in the mouth can be really, really sore. So again, it's just trying to figure out if we can get treatment started for that as soon as possible, and that's definitely the best. Discomfort wise, the thing that causes the most discomfort really is the cough, the cold, and the mouth. The hands and the feet, yeah, they might be a little bit itchy, but it's not itchy like a chickenpox rash would be itchy. But just keeping everywhere really well moisturized, and again, hygiene advice for parents and childcare facilities at home. On to some of the eczemas. So eczema is a really difficult one in children, and particularly because everybody knows somebody that's got eczema. And when parents talk to each other and, child starts to, oh, it must be eczema. Yeah, it's got eczema. And don't get me wrong, a high portion of children and particularly babies do have eczema at some point, but it doesn't mean that they're going to have that forever. So it presents with a dry, itchy skin. Again, usually on those sort of like warm areas, so backs of knees, in between elbows, armpits, anywhere that's, top of the nappy area for babies is a good one because it's high in moisture and it's warm, and it's the perfect place for eczema to start. Can be chronic with flares if you don't get it under management. Is most common in children, like I've said, a high proportion of children and babies will present with eczema at some point. Can get eczema on the face, definitely more difficult to manage. But I think one of the things that I would really suggest and really recommend is we don't rush in with steroid creams and things like that, because it's just not great for the skin barrier. Once you get into that steroid cycle, it's really, really difficult to break that. Children are more likely to have eczema if one or both of parents have eczema. Um, the child or a close family member, mum, dad, has asthma or hay fever. So we refer to asthma, hay fever, and eczema as sort of like the triangle. If mum or dad has one of these, then baby will have one or the other. So it sort of like presents in a bit of a cycle. So again, that's why our history is so important, getting that history as well. So can be made worse by coming into contact with allergens, irritants. Washing detergents are a terrible one. Soaps, shampoos for slightly older children if they're, getting a bit confident and starting to use things like deodorants and body sprays and things like that cause havoc with the skin. Um, Other allergens such as dust mites or hay fever, certain foods can flare, especially with babies. If you've got a parent presenting with a baby with frequent eczema flares, obviously we'd be referring that back. But I think one of the things to ask these parents to do is, do you want to keep a food diary? Do you want to see, is it milk? Is it wheat? Is it gluten? Is it anything that child's having that is flaring up their eczema, because it can be really, really common. Changes in heat and temperature, usually when it starts to warm up or cool down, people tend to have a bit of a flare, especially as we head into the winter months and your skin naturally dries out anyway because we've got the cold weather. It's really, really hard to get back on top of that then. Skin infections like staph can flare up your eczema. Stress, I mean, hope our children aren't stressed, but sort of older children and teenagers that are heading into exam season and things like that. Again, ask these things. Is there anything going on that's causing you stress? I'm sure those of you that have got children are very aware that exam season tends to be in the summer, and that's when all of these health conditions tend to present in our teenagers and older children. It's not contagious, so you can't catch or spread it. But the best thing to do is just keep the skin really well hydrated, really well moisturized. So we've obviously got a whole host of different emollients and things that we can provide in community pharmacy. And then for our more severe cases, we will be looking at the steroid creams, but I really, really would strongly suggest we avoid those for as long as possible. Parents might come and ask you about natural remedies. So it's finding a treatment that works for that child. And everybody's skin is slightly different. Everybody will react slightly differently to emollients and creams, lotions, potions, natural remedies, because everybody's skin has a different sort of like reaction to that oil, water base that we're trying to get just right to treat the eczema. Things like oat baths tend to work quite well and is very inexpensive for parents. There's all sorts of creams and things on the market, but it's really important that if they come to you with sort of, should I be using this over this? Should I be using that over that? At the end of the day, it's sort of like patient and parent and carer choice. So as much as we can say, well, scientifically, yes, that probably would work, we can't sort of be seen to be pushing parents down a certain route when it comes to the cosmetic side of selling products and things like that. So a few different pictures of how eczema can present. Like I said, usually those creasy areas, warm areas, backs of knees, elbows, etc. Our little babe here with eczema on his face. Can be really hard to get on top of, especially when we get to the age where they're dribbling or, as babies, they're spitting up milk and things like that. So it can be hard to get on top of because we're constantly wiping and abrasing the skin with whatever we're using to clean them up. So on to discoid eczema. Is more distinct really than our atopic eczema in the sense that it comes in sort of circular and oval patches. The first sign is usually a group of small spots or bumps on the skin, and you usually find that parents say, "Oh, yeah, I've just been keeping an eye on it," but it is progressing. They then sort of quickly join up together and they form these larger patches. They can range from small patches, a few millimeters, to several centimeters in size, and it does tend to happen quite rapidly. especially when triggered by an allergy or the weather. On lighter skin, they can be sort of like a pink/reddy colour. On darker skin, they'll be a more darker brown, or on the flip side of that, they could be a lighter brown, but you can definitely see that difference in skin tone and texture. Initially, they're sort of swollen slightly and look almost blistered with little fluid-filled pockets on, and they can ooze fluid. Can be very itchy, particularly at night, because we've got, we've put the pajamas on and we've put them to bed and they're warm under the covers, and that's when the itching starts. So it can cause a lot of problems for sleep. Over time, as this progresses, the patches can become more dry and crusty, like cracked, and they start to flake. The center of the patch can clear, and then it leaves sort of like a ring of discolored skin around the edge, which parents will then panic and think that they've got ringworm. So it's just setting out those expectations of, as we go through the healing process with this is what it can start to look like. Funnily enough, doesn't usually affect the face or the scalp. It tends to be sort of like chest downwards. But an outbreak of discoid eczema can sometimes be triggered by little skin injuries or insect bites, burns, and things like that. It tends to come from your body's response to some sort of injury. So this is what it tends to look like. So as you can see, again, I've tried to put a few different skin tone examples in there for you so you can kind of get an idea of what it would look like. Little babe here up at the top, again, that warm area. We know that younger babies, they don't tend to move their arms from their sides too much, and they're pretty immobile. And then unlike sort of your atopic eczema, they don't tend to be localized to those warm sort of creasy areas like the backs of the knees and elbows and things like that. You can find sort of random patches all over the body, and might not be localized to one area of the body. You might just have a couple of patches on your arm, one on the back of your leg, one on your shoulder blade. And sometimes when it initially starts and it's sort of that like those crusty circles, a lot of people jump straight to psoriasis and they think it's psoriasis, but we know that is probably less likely to be the case in children specifically. On to contact dermatitis, which kind of falls within the eczema family, but I would argue also kind of doesn't. Usually comes from sort of some sort of irritation or allergic reaction. The skin becomes itchy, blistered, dry, cracked, and it usually comes on within a few hours or days of exposure to that. If you do get adults in, they've usually used some sort of cleaning product, and that's what set them off. Again, children that have got into mum's makeup case or skincare case, and they've started using things, and then a few hours or a couple of days later, they'll come out with this sort of rash. Can affect any part of the body, but most commonly on the hands and the face, usually the hands, because that's what come into contact with the irritant itself. So this is what that looks like. Dry, cracked. You can tell people that work with sort of like irritants and chemicals and things like that, and that definitely aren't wearing their PPE because it's localized to the hands, the wrists, etc. Underneath, especially now that young people are starting to use sort of Apple Watches, Samsung Watches, smartwatches, can get sort of like the rash underneath where their watch would sit, rings, and unfortunately like cheap jewelry and things like that they're buying off, I don't know what sites these days, but can tend to really irritate the skin. So what can we do for any of these sort of eczema conditions? We want to be reinforcing medical emollients and treatment, not this, that, and the other that you can buy off the internet, or Sarah down the road has said it worked wonders and things like that, especially those things where if you look into it properly, there's no evidence base. And we want to avoid parents going around the houses, trying loads of different things, feeling like they've got no choice because none of these are working, and we're going to jump straight to steroids, because that tends to be the cycle they get into. And advising parents that you're going to have to give this some time. It's not instantly going to get better. We're looking at a few weeks to get on top of this, rehydrate the skin, and hopefully see some progress. Soap substitutes. Soaps are a massive irritant. Again, with washing powders and things as well. I encourage parents to be using non-bio. Avoiding those triggers. So if we've kept a bit of a food diary and we know it's milk, then we need to cut milk out of the diet. If we know it's gluten, we need to cut that out of the diet. Triggers such as hay fever, we're taking antihistamines for to hopefully manage. When we want to be referring on, if there's any weeping or crusting, any rapid worsening, and we're thinking we're not going to get on top of this here, or anyone with eczema herpeticum, which is a serious skin infection, so they need an immediate referral. I probably wouldn't be referring back to the GP here. We'd be going to urgent care. Basically, what it is a widespread infection caused by the eczema. So a lot of the patches might be using fluid, they might be crusty, yellow, and when I say yellow, I'm talking, that infection yellowy colour. The skin around the patches can become hot, swollen, tender, painful. They can feel sick, hot, cold, shivery. So anybody with eczema, we're not expecting them, unless there's something else going on, we're not expecting them to be presenting as unwell. So if we've got any of these signs of infection, please do refer on immediately, and they'll need to be seen and treated for that. So a big part, and I have touched on this throughout slightly, a big part of, diagnosing skin conditions and things like that is managing the parents and carers. Essentially what we're trying to do is build confidence in them, communicate with them clearly, and then essentially we want to be reducing the chance of them having to come back. So we've given them all the information that they need, we've given them their treatment options, and they know where to go next if it's not working. Skin conditions and rashes and things like that, particularly when they affect the face and the hands, parents can be quite upset about and worried that it's never going to clear, it's going to get worse, and that they're going to be left with scarring, etc. So we just want to make sure that we're giving clear explanations and expectations of what to expect during the healing process. Avoid jargon where possible. I'm sure a lot of you know your families anyway, and you know sort of what knowledge base and things they have, and we know how to communicate with them anyway. And be honest. If you don't know, I'd just say that you don't know, and that will build confidence and trust in you as a professional as well. If you say, you know what, I'm not too sure. Why don't you pop back in a couple of days? I'll have another look. Or I'm not too sure. I think I'm just going to refer you back to your GP or urgent care if needed, just to get a second opinion. And then they're not feeling fobbed off. They're building that confidence in you, and you so in them as well, that they'll hopefully come back to you in a couple of days' time just to get you to have a second look. We want to provide a really strong safety netting. So I did touch on this in the last webinar, but I have got a few slides in a moment as well, just to touch on that. One of the big things parents will ask you about is school exclusions. So gov.co.uk, I've got a list of school exclusions. It's really handy. It's just been popped in the chat there. Just to print, stick on the wall, and then if you've got anybody in for a consultation, you can say, right, they've got this condition, so they'll need to be off school or childcare for however long, and it'll tell you on there. That's what the schools follow, and that's what they can use for sort of their attendance policy and things like that. So parents aren't going to be in trouble for keeping them off. One of the best things I've found to do, and I mean, I do this with most things anyway, not just skin, get parents to take pictures just to monitor how it's going. The best person to reassess a skin condition is the person that's seen it initially. So if they're bringing that child to you on the Tuesday, and you're saying, right, okay, it looks okay for now, let's just keep an eye on it. Why don't you come back on Friday and we'll have another little look? You've seen that, you've got fresh eyes on it. So rather than writing some notes and saying, I'm going to refer you back to the GP to be seen later in the week, and the GP's reading these notes thinking, well, that's great, but I'm just building some sort of picture in my mind here. Try and get them to come back to you if possible. And if they can take pictures of the progress during the course of that week, what does it look like after a bath? when they've been moisturized? What does it look like when they've just woke up in the morning, when they've been all snuggly in their sleeping bag or under their blankets and things like that? So it can give you a real good idea of sort of trigger points and things like that as well. So as I mentioned, safety netting, parents need to know these things to feel comfortable and confident in the care that you're giving them and the advice that you're giving them. So they need to know what to expect, when to seek help again, if we're saying you can probably come back in a few days. Where are they going to go? If you're giving them advice that they need a re-review in 2 days and it's, a Thursday, we need to take into consideration that the GP is not going to be open. And what time frame are we looking at if they want to be reviewed, if they need to be reviewed again? So this strong safety netting just helps reduce any unnecessary referrals, improves patient self-management. They know to expect that it's going to look worse before it looks better, and things like that. We just need to be providing this clear, specific advice using our accessible language that parents are going to understand. And one of the most important things, and I stress this, I think with every session I give, document the advice that you've given really, really clearly. One thing we're not so great at in community pharmacy is really clear documentation. So I did cover it last time and I will cover it again. We've got a little bit of a case study to go through next, just to sort of go over some of the things that are really useful to document and some of the things that cover you as a professional as well. So if we're referring on, we need to know our local referral pathways. So one of the great tools that the NHS have provided for this is the service finder. So that's great. It's really local to you. CPLSC website has lots of local services on as well. Underneath the public health page, if you just search for that. NHS 111 is always a good one for urgent advice. My advice would be if you're contacting NHS 111 about a patient because it's, I don't know, 5 p.m. on a Friday evening, you should be doing that with the patient in the pharmacy with you. So we don't want to be sending them away and then 111 not be able to get in touch with them or they lose signal or whatever. If you're escalating a concern about that patient, please do it whilst that patient is with you. Same day referrals with a GP if it's obviously during the week. Again, if you're contacting that GP via phone for an urgent referral, please do it with the patient in the room and it just cuts out some of that in the middle. Okay, we'll get in touch with them, couldn't get in touch with mum, and then the back and forward trying, and this child is without treatment for an extra however many hours. A&E for emergencies, naturally we're trying to reduce A&E attendances where possible, but we know as professionals when to be given that advice that patients need to be going to A&E. And document and signpost always. So if any patient is coming and using your service, your pharmacy, more than twice within, we would say, a month's period with the same symptoms, they don't really need an urgent referral. They're just sort of tootling along, parents not happy, or it's progressing slowly, and is getting slightly worse. We should be considering referring back, and that's not just with skin. That's with with any condition. If you're seeing that patient regularly, with no sort of clear outcome or definitive end, then we should be referring them back to the GP for further referral. In the case of skin, it's usually a dermatology referral. Safeguarding is always one that I like to mention. So for specific contact details and guidance for safeguarding teams, there's information on the CPLSC website and the link will go into the chat as well. Any concerns, query with inconsistent history, especially things with, I've not covered it in particular here, but unfortunately things with nappy rash, persistent thrush, etc. I'd be starting to think that we need to be putting a mass referral in or speaking to some wider safeguarding services just to touch base. You can never be too safe. Any frequent attendances and you're just not getting the right vibe that things are quite right, trust your gut. Your professional gut is usually right, and even if it's not, you've done absolutely no harm by just raising the question and just getting some clarification on that. Any delayed care seeking, so say, oh, we've had this eczema for 6 weeks and, we've not done anything about it. Well, why have you not done anything about it? And now the skin's really, really sore. Any natural signs of neglect or harm, any concerning parental behaviour, any concerns that parents are under the influence or, not in a position to be caring for that child appropriately. And again, concerning behaviour from child. Are they really sort of, resistant to speak to you? Are they looking a bit wary? Is parent talking over child all the time, which as parents we can do, but for children of a certain age, I'd be saying 5 really. I'd be asking the child the questions about their own health and trying to get them to communicate with us. Also to build trust and, progress them through the healthcare system as they're growing up. In community pharmacy, safeguarding concerns, they usually present as minor ailments, and then you look twice, and this is why our electronic referrals are so important. We've got a log and we've got, accountability for every contact of this patient, because we can see where they've been, what they've been seeking treatment for, and we can make sure that they're not sort of pharmacy hopping, going to you and then a pharmacy down the road, and at least all of this information is being fed back to the GP for each presentation. So document thoroughly. I, as a nurse, naturally use SBAR. There are loads of different frameworks that you can use. I just find this is the most straightforward and simple one. So situation is sort of what's happening right now. So for example, Jessica Jones is 5. She's come in. We've weighed her because that's always a great thing to do with children. I did touch on this in the last webinar, but weigh them where possible, even if it means parents standing on the scales with them in their arms and then, taking parents' weight off. It just means that we're giving the right dosage, and for our bigger children and our smaller children that might be the same age, we're not over or underdosing. So Jessica's got a 5-day history of a 50p size spot on her cheek, several other yellow crusty lesions on the chin. Otherwise, she's well. Mum's here and she states she's got parental responsibility. So that gives us a really good picture of the situation of what is happening now. Background. Any relevant clinical context. So she's previously been reviewed in community pharmacy, and she's been using hydrogen peroxide for three days, but there's no improvement. Remains localized, hasn't spread anywhere. Her immunisations are up to date. She's not got any allergies, and at the moment I've got no safeguarding concerns. So that gives us a basic understanding of what's been happening over the last few days and what's caused Jessica's mum to bring her back in. Assessment, so we're looking at your clinical impression. Again, we're not asking you to be an expert. We're not asking you to diagnose as soon as they come in the door. We're just giving what we're seeing at that moment in time in our assessment. So she's alert, she's interactive, she's chatty, eating and drinking, no breathing difficulties. So we know that generally she's well. Impetigo remains localized because that was diagnosed previously. So now we're looking at she's going to need some further treatment because of the ineffectiveness of the previous treatment. So we're doing all this on the Pharmacy First formulary. Recommendations. So what's the plan now? So we've prescribed her fusidic acid. We've given her lots of hygiene advice, and we've given some safety netting advice. If the infection becomes more widespread or there's no improvement, then she might need antibiotics. So we're telling her that, we must have seen her at the start of the week because we're telling her to see the GP if she needs a further review, and we've given her the school exclusion list that I've sent earlier. So we've seen this patient twice now. If she was to re-attend, we'd be sending her straight back to the GP. So key messages, most rashes are self-limiting. Pharmacy can manage so many safely. Again, we're trying to get patients to seek the right healthcare at the right place at the first time. Red flags protect patients and yourselves. So taking note of those red flags and even documenting when you've excluded those red flags, aka Jessica was well, she was bright, she was alert, she didn't have a temperature. It just shows that you've covered your full assessment and you know what the red flags are, even though you've excluded them. You've mentioned that you've excluded them. And confidence and communication reduce consultation. So having that clear communication with parents, setting out that safety netting, setting out those, expectations of what is going to come over the next week or so, is going to reduce parents coming back time and time again. It's going to reduce the likelihood of them going back to the GP. It's going to reduce the likelihood of them then going to urgent care because they know what to expect and they feel confident in the advice that we've given them. And again, confident in us when we say, actually, I'm not too sure, so I'm going to get a second opinion, or I want you to come back in a few days. So I've popped some references on there. I'll pop those in the chat after we've finished. And there's lots of links and things in the chat there for you to have a look at, print out, pop on the wall, start a folder, whatever you want to do. They're just really helpful, especially when you've got maybe locums in that might be running your pharmacy first service and they might not be too sure. It's just nice to have some visuals. So, right on time, a minute over. I've left 10 minutes there for questions. If anybody has a question, feel free to stick your hand up or pop it in the chat and I will answer it for you. If you're too shy now and you don't want to ask anything, the chat will still be open after the session for you to pop any questions in. So I will open the floor to you. Otherwise, if you don't have any questions, feel free to pop off and go grab your lunch or a brew or whatever you're planning on doing next. I'm going to take that radio silence as everyone's happy. So I will bid you farewell. Thank you very much for joining us, and look forward to the next one. So when details of that are available, we'll release it on our newsletter as usual. So make sure you signed up, and I'll see you all next time. Thank you.